Welcome. Good evening, everyone. Welcome to University of the West for a special lecture featuring Dr. Ali Chavoshian. My name is Fong Sam, and I have the distinct honor of introducing Dr. Chavoshian tonight. He is a clinical psychologist and a research psychoanalyst practicing in Berkeley, California. He is a faculty member of the San Francisco Lacanian School of Psychoanalysis. He is also a clinical faculty member at the Wright Institute in Berkeley, serving as a clinical supervisor for graduate students. In addition, he has served as the academic dean and professor in the Graduate School of Psychology at the New College of California in San Francisco since 1990, and as well as the teaching faculty at Sonoma State University and the City College of San Francisco. Dr. Chavoshian has been a visiting professor at the Quilin School of Medicine, Department of Psychiatry in Rast, Iran. His clinical research includes the discussion of culture and society. Please give a warm welcome to Dr. Chavoshian.
Thank you. Okay. Can anybody hear me? Everybody hear me? It sounds good.
Loud and clear.
All right. Thank you. Well, thank you, Afan. I will humbly take your introduction and incorporate them in navigating the zeitgeist of the art of listening. So I'm going to be reading some of the notes that I took. Then I will discuss some. I present the art of listening to you today with my own twist and turn that I have acquired after 44 years experience of clinical and academic and administrative work in public, private sectors, and so on. I started my career as a young psychologist in southern state, first with youth and then in the biggest mental institutions or a state hospital in the state of Virginia. I was very enthusiastic, successful in treating my patient with hardcore science, evidence-based therapy, quantitative approach to treatment, cognitive behavior, along with other team of doctors, pharmacists, nurses, psychiatrists, neurologists, and so. I would take so much pride to present my clinical work nationally and internationally and meeting new colleagues in the field. I pursued the same when I arrived at the Bay Area in early 80s. I began to do forensic work and clinical work at Berkeley Court and Berkeley Mental Health, along with my private practice, as well as teaching and administrative work as dean and professor in the different colleges in the University of the Bay Area. In the meantime, I've been a visiting professor in my hometown, Rasht, Iran, at the Department of Psychiatry, where I would go there to teach every summer. Besides, I was a media doctor with my live weekly TV and radio program, like Dr. Phil. So everything looks good, right? Except when this happened. Suddenly I realized that I'm frequently encountering many individuals in public, both in the United States and Iran, who would come to me and praise me for my good work and thank me what I have done for them. The problem was that most of the time I couldn't recognize them and vaguely remember that I had therapeutic relationship with them in one point. I knew it was too soon for me to suffer from some kind of amnesia or dementia. Later on in my analytical training, I discovered that in my work as a clinician, I never listened to them as an individual, but tried to classify them in general categories of symptom problems, despite of receiving so many compliments that I was a good listener. In my listening, I was preoccupied, as I was taught in my training, how I would diagnose, treat them in generality. I didn't see them as a singular, but in general. I came to realization that this might be the reason I didn't have recollection or recognizing my patient. I then decided to shift to new kind of listening and new approach. I decided to go to the session with no preoccupation, with theory and technique, and stay fresh with the here and now experience of listening. For a while, I was unable to do so. Just the idea of listening with a clear mind was too much of anxiety provoking, and it was difficult to contain the anxiety. The feeling was as though I had lost my identity as a doctor and had nothing to offer to my patients. It's like you just find out that you're fired and you can't work anymore. Of course, I have overcome this anxiety in my training as an analyst, in my personal analysis, and it was just at that moment of my entering the new form of listening that I realized I could no longer go back to the old mode or old way of operating. So here it is based upon these experiences that I'm offering you my own view of the art of listening. It goes as follows. Listening is the fundamental principle of psychotherapy. All approaches to listening should concern itself to the question, just two simple questions, how and what? How to listen, what to listen. The question of how help us to create a process-oriented psychotherapy, rather content-oriented psychotherapy. The process-oriented psychotherapy allows the content to be presented fluently. The question of what concerns us to listen beyond spoken words, and it is referred listening beyond the symptoms. In the first part of this presentation, I described the principle of how and what. In the second, I will demonstrate this principle in a clinical formulation. First, the question of how. Listening is related to the anxiety. It is the ability of the analyst, doctor, psychologist, therapist, counselor, spiritual director, hospital chaplains, and healer to learn how to hold, contain, maintain, and manage her or his anxiety in listening. So when I say I'm going to be using a lot of time the word analyst and patient, but they're interchangeable. You can have a setting like counseling. You can have a setting like psychotherapy. The setting might be different, but the principle of listening that I'm offering you, apply it the same. You can apply it in a conversation between your friends, family members. Listening is related to the desire of the analyst. So I'm putting more in a relationship, in a counseling or patient and doctor relationship. I'm putting more here analyzing the doctor, because we have to be clear where we're coming, how we listen to help others. So listening is related first to the desire of analyst, rather to desire of patient, client, spiritual directee, individual, subject, and liaison. You can name it whatever you want. The desire of the analyst is the desire of other with big O. The analyst's desire of the other is her or his preoccupation with the past training and the knowledge of treatment modality. Can the analyst empty self from the desire, this desire, and listen with an empty mind in the here and now experience of listening? Removing desire requires listener to damage its narcissism. So imagine that we go to the session, we say that forget about my training. I'm just going to be sitting over there with blank mind. It is a lot of challenge because our narcissism is our title, our knowledge. Without that, how would you define yourself as a listener? In fact, if you remove yourself with all of this narcissism and take a neutral position, you'll be able not to judge. We get to that point. Listening is encountering the fear of unknown. So if you remove all of that, there's an unknown situation because you don't know what the person, you'd be surprised how much or what the patient can say or do. So that unknown thing, that what you do, can you answer it? What formula do you have? This fear of unknown, in the language of Nicholas of Cusa, the 15th century theologian, it is encountering the learned ignorance. So Nicholas of Cusa saying that there are two kinds of ignorance. One is learned ignorance, which is good, meaning that you know that you don't know. There's the other ignorance he called passion for ignorance. That means that you don't know that you don't know. So, but in terms of what listening is to go beyond the sound of the speech. So there are two ways of listening. We listen only to the sound. That's the lower part of listening. That is part of what we call the hindbrain, the animal part of us. But how we go beyond the speech? The ear should function as the trained instrument that reflect the exact word of the speaker. Only the skillful and humanized ear can reflect the suffering of the speaker. So that is a skill that requires to go beyond the sound. When you sound, you go beyond the sound that you humanize in your ears. In the language, again, Theodor Reich, a Viennese psychoanalyst, meaning listening with the third eye. So the last point about listening is not equivalent with silence. Because one can be silenced. How do you know if somebody is silent is listening? We don't know. The listener can be silent out of anger, confusion, boredom, or not knowing what to say. Rather, listening includes reflection, inquiry for exploitation, or it could be all kind of sophisticated income. Silence, though, is not equal with listening. Okay, so this is some of the principles that I was going to build up for listening. And at this point, maybe I should read you a clinical case, and we will see how we can apply that to this concept of listening. I'm going to introduce this patient to you, and it is very much, I have changed so much information about this patient, almost become fictional because of confidentiality and legal issue or ethical issue, I would say. So here is the background. Patient is a 72 years old, devout Muslim woman, referred to me by her faith leader, we call it Imam, spiritual director. The reason for referral was that the patient was displaying a wide range of clinical symptoms, which was interfering with her spiritual work. Prior to coming to see me, the patient had a stroke due to high blood pressure just a month ago. I also realized she was placed on psychotropic medication for delusional disorder before discharge from the hospital. After her evaluation, I came to conclusion that she's suffering from a typical depression with melancholia. So I would explain that later. With melancholic feature common among the elderly population, and delusion is not warranted, rather the result of a stroke, which normally should disappear in a short period of time. Therefore, I asked the treating psychiatrist to discontinue the patient's med, and then I began the treatment. In fact, after the medication was discontinued, she was more coherent, she was not numb, she could speak. Complaining problems. Patient has been preoccupied with the death of her mother for 20 years. She also feels that God will punish her for raising a child, quote, who has become a lesbian. So what I did here, I'm going to present some of the experts from the middle session, analysis of experts from a session from the middle part of the treatment, and demonstrate that those principles of listening that I mentioned, how I applied here. Here is some of the dialogue the patient start in this session. Well, hello, how are you? I'm so glad to see you, and I'm lucky that you're my doctor. I feel I can talk with you about all of my problems because we're from the same faith and background. I'm not sure about the same faith and background. Usually, patients come and idealize you, and they assume that they have a lot of commonality, including culture. So you continue listening. The assumption would be that there is no reason to get involved saying, no, I don't have the same faith or this and that. That is part of the thing that they want to idealize you. In some degree, you just quiet and listen. Plus, she's not asking any question. As far as she's not asking any question, I'm listening. But here is the piece that she's adding. Before I start, I should ask you if you're okay. You seem to be pale and weak. Every week it is getting worse. Do you sleep and eat enough? Is your wife taking care of you? So I know that I was not pale. I knew that I was not pale and I was eating okay. So what would you do if somebody present that? Again, you continue to listen. And there's a reason she's saying that. It's very common among elderly who have physical problems and have some fear of death and dying. They have to distract themselves, disown that part of themselves by attributing that to others. And the closest person is the doctor. It's called projection. That gives them a relief. And maybe we'll talk about later how I dealt with that piece. There's a short silence. Well, last week was horrible as usual. You see that these general things she's talking about, and there's a silence. If I'm not nervous, I'm not trying to rescue her, she immediately go from culture, you and that, talking about her problem. First, I have been thinking about my mother and how much I miss her, even she died 20 years ago. I can't accept her death. She lives with me every moment, crying, short silence. Then I couldn't sleep all night because I was thinking over and over what my mother told me. She told me once, your daughter, quote, your daughter is lesbian and God can punish you for that. Continue crying, long silence. So this silence is getting long. Remember, that is not my silence I'm talking about, it's patient silence. What would you do again in this kind of listening? Would you jump in to rescue or hear what you do sometimes? Listening is not absolute silence. You reflect what the person say, and that would allow the person to reflect on her life or explore. So here, for the first time, because the silence was getting long, I say, your daughter is lesbian and God can punish you for that. So I reflected exactly what she presented to me. Then she elaborated further, patient. Yes, mom thought I didn't spend enough time with my daughter and didn't raise her properly. I didn't have a choice. I was a single mom and had to go to school and work. Our faith leader in the community is saying that it is not true. It is not true what your mother said. There's an old-fashioned way of thinking. Nothing in Quran is saying that. I read patient saying. I read Quran several times. There are remarks about male homosexuality, but nothing about female. All of the physicians are telling me that I have tremendous stress and my blood pressure is very high. They say if I have a stroke and heart attack again, they may not be able to save me this time. Then suddenly seems frightened, anxious, and crying. Then she say, I hope I won't go to hell after I die. Again, silent. So here I say more. Explain it to me more. Patient, considering my mother said, it's a possibility. It's a possibility I go to hell. But my faith leaders say, Allah, God, is forgiving. Continue praying, saying Allahu Akbar means God is great, and asking for forgiveness. Then it spoke in a lengthy way, in detail, talking about the concept of hell and heaven. So I was quiet, I listened. I brought two contingencies to listening. One is repeating exactly what she said. She explored more, and I asked her to say more. And from a technical point of view, or from our other doctor that I presented in conferences, that's supposed to be a successful session, because without I get inquiry, advising, doing anything, she produced a lot. She discharged herself. She told me a lot about herself. I didn't need to do anything. Let me do a little bit more analysis here because of time. Let me see. Oh, we have almost 30 minutes. First of all, the clinical thing that I resolve it. What is this a typical depression with melancholy? For elderly, the depression is not like the classic one we see in adult, like disturbance in eating, sleeping, some suicide ideation. The elderly, that I work a lot of them with different culture, coming from different culture, they usually report that they always obsess about the past. And it is like every night their past is like a tape recorder or like actually a video with some frozen moment picture that called ruminating thought, intrusive thought. And there's such a thing called morning blue when they get up at 4 o'clock or 3 o'clock in the morning and they started thinking about that. But here we have melancholy. Melancholy is usually when you have a lost loved one, it usually takes 6 months, a year, that it would go away. But if it takes longer, that is not mourning anymore. Then we look at that, what was the relationship of the person, in this case, with the patient, with her mother, with the deceased one. We find a lot of complication. In this case, one of the reasons why the patient couldn't stop thinking about her mother, it was not actually the love and missing her. There was a lot of anger and hate there, because all of this authoritarian, controlling imposition, the belief that all of that would impinge upon her. So after she was able to talk about it, a lot of these depression cleared. But we had another problem, which is this, with the issue of faith. The core conflict for the patient is getting caught up between two versions of Islam and what I call the two grand narrative. One narrative presented by her mother is stating that she will be punished by God for raising, quote, a lesbian daughter. Another narrative represented by the spiritual leader that God is forgiving. None of the narratives are her own, and they're presented to her. If we interpret the narratives in terms of desire of the patient, we can say her desire is the desire of the other, meaning for her desire wanting to know what's going to happen to her in terms of her religious belief is based upon narrative that's given by others. In this session, she doesn't speak about her own desire. This thing about going to hell, it is not that something really her own way of talking. It's a borrowed narrative. It's a script. It's a formula. So at that point, when she speaks about all of that, she doesn't speak of her own desire, but rather it's spoken. She's spoken by the desire of the other. The ultimate goal of treatment would be if she can be the author of her own desire and speak of her own desire and be in peace with herself and her decision. This can be done when the analyst is listening and the patient is speaking. We can never underestimate the power of listening and analysis and the power of speech. Speech moves into many directions and creates so many possibilities, where in the beginning they seem impossible. This happened when the patient moved from empty speech to full speech. Empty is what you reflect somebody's narrative as your identity and claim that as yours. You don't even know that. Full speech in analysis, when you, after repeating this narrative given to you on, and rewriting your narrative, you get a moment that really happened. So you can say that, I got it. That was not me that I was talking. A lot of affect comes. This is me. That is full speech. But now, this is not education. You cannot tell a person that this is what's happening to you, you're borrowing the narrative from this. It is a process. That's the reason why I say psychotherapy. Any listening is a process. It is in the process of that, the speaker, if has a chance to speak about it and go through this motion, it's not a cerebral intellectual process, it's an emotional process. The person will have this aha experience I told you. But before I demonstrate the art of listening, I would like to demonstrate how a grand narrative and desires constitute. The following model, referred as the mirror stage, describe the constitution of desire in human beings. So I'm presenting this simple 5 version of that how we adopt all of this prescription that given to us and claim it, so stay with it so hard and suffering, and then we realize this is not ours. Unfortunately, in this case, for this patient at the age of 72, here what happened. When the child is born, because of prematurity of the birth, child is not coordinated, the infant, in fact, and doesn't develop the whole psyche and cognitive process in a full manner. From the age of 6 months to 12 or 18, child adopt an identity. And what happened, we use this mirror stage as an example. With the child, the human infant, when look at the mirror, is very excited, a jubilant child, assuming that she or he look at this picture, see herself together. Inside, the infant is not together. There's a lot of senses and emotion chaos. And then from outside, we're just giving you an analogy. The mother come with a finger, say, Susie or Johnny, that is you. So you develop something from outside. We can use the mirror stage as an analogy because all of the mothering, which mother means primary caretaker, not biological mother, prompting the child to be certain way, to adapt, because even the child is born, we adopt a name for it with a lot of goals the parents that couldn't achieve. It is all a demand and imposition the child. So in reality, there are 2 kinds of child. One is very adaptive, polite, and listening. The other is building this sense of unrest, anxiety. And as an adult, we also have, by the way, as an infant and child in us never go away, because as an adult, we develop this duality, this paradoxical way of being that we have an obedient child and an unrest, an anxious child that could not meet all of those ideals. Here, to simplify it, I'm going to use this topography map and a little bit of the Bromian ring to demonstrate. Think about the child or us. We are 2 kinds of people. One is called public self. The other is private self. Public self follow the morality and ethics of the rule of civilization. sexualized or sexual morality, or all kind of anxiety and emotion around that. The private self is the one who is depressed, anxious. The public self, constantly we see it from outside. We don't see individual private self. This private self happen when they come in the privacy home. It's all happening to them. But here is the trick. Sometimes that private self itself is alien to the person. The public self is so huge, controlling that cover the private self. So in fact, symptom is nothing in a simple language, is the contradiction or the conflict between public self and private self. And in case of this patient, we have the public self and grand narrative that imposed to her by this rule that about the mother, the logic of sin, and the daughter, lesbian daughter, all of that. To a point that she really adopted, and that is this narrative that imposed upon her. And her symptom, which is a typical depression with melancholy, is a result of the conflict. This is as simplified could be described. So here I'm asking the question, or I'm posing the question for anybody who is in the field. When you listen, well, this is, I'm calling the structure of the mind of this patient. What we see is the symptom. We don't see the public self, private self. We don't really know what happened. But when you listen, where is the listening position itself? Do you just listen to the symptom? If you get rid of symptom, what about the hidden part? You don't see it. Do you listen to the private self? Do you listen to public self? That's the challenge. Now, if the listening is successful in the long term, if the patient managed to navigate through all of this area and then abandon or even incorporate all of that and write his or her own narrative, make his own decision, well, I'm going to be from now on myself. How would she can do it at age of 72 and that you're not able to abandon, you cannot get rid of your symptom, but you can incorporate it. And here what would happen, she can add another ring to it. When she writes that narrative, so if you listen carefully and allow the person navigate through all aspects of area, not just symptom reduction, because psychiatry, medication, all kinds of techniques are trying to get rid of the symptom, but they don't see there are different aspects of yourself that have not been touched. And the struggle of the speaking subject, meaning the patient, is how to navigate. It doesn't come, you educate the patient. If you listen and move around without judgment, the patient will be able to rearrange the rings, untie the rings, put them together, but develop a safety. Here it's called symptom, meaning manage to make her own decision and not pay attention to this indoctrination. Why symptom? Symptom. First of all, as a stranger, I'm doing some literature review. Symptom is a homophony with symptom. And it comes from the story of St. Thomas. St. Thomas, in fact, was the one who didn't accept the grand narrative of Jesus and resurrection. St. Thomas said, I want to see the wound, then make a decision about the resurrection. Here, St. Thomas went beyond the grand narrative that given to him and wrote his own narrative or desire. So in a way, we are telling our patient, be like St. Thomas, write your own narrative. Now, let me just say a few words and then finish it because of time. But none of this could happen only when one person speaks and one person listens. First, when they come, they speak about they have a reason to suffer. This is my symptom. This is causing my problem. You got to do something about it. I can't take it anymore. In the language, in linguistic term, it's called metaphor. It means the person see only a limited version of her problem, only see the symptom. As the person speak, as his speech move, not in a causal relationship, move all over, we have another scenario called metonymy. Let me give you an example. I treat a lot of patients who attempted suicide and they, which is something that I can get credit for what I have done so far, because I know that I helped them. And without me, they couldn't do that. But what they described, that there are moments that they could not see any way to get out of their problem. In fact, suicide is an impulse. The person could be doing okay in one point, is depressed, can jump from the building or do something. But when the person talks about that point, about that problem, it is a metaphor, meaning that I only know that A causing B. But as I help them and they speak, and then there were time, a treatment that was over, they started even laughing. So what was wrong to me? There are many ways I could look at this issue. There are plenty doors open to me now. But at that moment, when I tried to attempt suicide, I didn't see it. That is a good example of metaphor and metonymy. You know, as we listen, as the speaker speak, his speech moved to many levels. I told you about metaphor and metonymy. I'm going to say a few words, not to explain it. This is for future. Other thing, the speech or listening could position itself is called transference and countertransference. There's always speaker develop after a while some relationship which you idealize, good father, good mother, or even negatively. So how you position your listening in that process. See the listening getting more in depth here as you develop that therapeutic relation. The other is contain, how much you can contain, what you contain. The last part look like almost physics, but it is not. Alpha and beta sensation. Beta sensation is raw, crying, anger, all of that. But alpha is the result of beta. I mean, every single crying anger, there's a story behind that. And you'll be surprised, by listening, the speaker developed this raw sensation, cry, that you don't even, she or he doesn't know why she's crying, the story would pop up. And that is the art of listening. That as raw a feeling, a sound could be, it would find a context and content, a story, a real story, or a fantasy. And that only happened not interrupting the person, giving the person advice, but just listening with the third eyes, and listening the way that Nicholas of Cusa said, with learned ignorance, not to be afraid of the unknown. Okay, because of time, I say already said a lot, and thanks for listening anyway.
Well, thank you, Dr. Chavoshian, for tackling such a complex topic. I'm sure you could teach a whole class on just listening. And so we appreciate that you balanced the theories with a case study that you presented. So thank you for that. Everyone, we've now entered the Q&A session of our lecture. And if you like, you can unmute and ask directly, or you could also type your question into the chat box, and I'd be happy to read your question for you. Dr. Chavoshian, are you ready?
Yes.
Well, we have one question from Sophia. She says, in general, spirituality discourse emphasizes integration. In your view, how can you articulate the meaning of integration?
Integration, right? Integrating.
Sophia, would you like to elaborate?
Yes, because you seems to say that, okay, public narrative, private narrative, we are all kind of each kind of, the fragmented, somewhat assume that we are all fragmented, right? And then, but in general, spirituality or psychology, developmental psychology particularly, the high goal is kind of integration, integrating whole thing. So from your perspective of listening of art, how can you understand this view of integration?
I see. Well, one area for sure is the clinical symptom, which is problematic. As you see, this patient has been referred to me by the faith leader, the spiritual director, because she couldn't continue doing the work because of the clinical symptom. So, and the other thing would be around faith, the spiritual growth. And the way I see it, they are one adventure. And this question of how that could be integrated and the person go beyond symptom, and then the issue of spiritual direction, this is the task that I guess we should leave it to the speaker, to the patient, to the spiritual directee, that how she's gonna or he's gonna navigate through the process. It is not really a formula. It is something developed within the processes of our, that how far the person is going to go through that. And the question of how, of course, is that the person can claim that he's in charge. He's not written, he's not spoken, or she is the speaking subject, and claim, I have an impasses to my desire. I have this issue, but I can get along with my symptom. I can go further. So I pretty much see my role as a facilitator, as somebody who can to facilitate that. First, you have to understand the language of your directee. All of the minute things they speak. So that is what I look at. I wonder whether that's a very important issue, whether you have further comment or you would like to elaborate further.
The reason why I'm saying here is because somehow we have internally as a spiritual director, try to make a somewhat integrated, or I feel like maybe it is my fear, my anxiety as a spiritual director. On the one hand, some directee continue repeat the same word, Jesus saved my life, Jesus saved my life, whenever on the corner, or, mercy of Allah. But on the other hand, the person's narrative is so much changing. Even though one thing describe A, next day you talk about metonymy. But if it's just too much changing, I feel so uncomfortable. So it is my fear, or it is just a normal process. Then I feel like, where is the person's integrity? I can just ask that.
Well, that happened actually, because as the person go through this process of abandoning that something given to her, the person actually go to process of anxiety. I mean, since we're talking this spiritual direction here, I bring the language of Rumi. Rumi said this process, if it is speaking from the point of spirituality, transcendence is a process of that first you have to damage the ego, that your sense of narcissism, the sense that you're spoken from the other point of view, that is not yours. When it is damaged, then there's second stage, the stage of tremendous anxiety. This anxiety goes so that you cannot contain it. Then the point of containing the anxiety and make sense of what he called merging to that sense of totality. So in the language, if I make, I'm probably making it more complicated, in the language of Hegel, that a person be able to have this absolute consciousness where individuality, peculiarity, and universality all fall. The person find his niche, his place, his position in this universe, and can be alone. Now, that's the reason why our role is important. They cannot do it by themselves. Doctor, spiritual leader, the chaplains, and everybody, when through that process they're going, and they're like an infant losing it, that they lost their identity, what they have and what they're going to do. You're almost holding an infant, containing that infant that could stay on their feet. That's that as much as I could say. Yes.
Thank you.
Thank you.
Are there any questions for Dr. Chavoshian? Well, I have a question. You mentioned different settings that listening can play a big role in, and certainly this skill is very beneficial in a broad range of fields and professions. And you also mentioned that listening, communication goes beyond words. So as someone who is in a position of a therapist or an analyst or even a chaplain, I would imagine culture comes into play is an important factor. Understanding the nuance of communication without words, and to take that a step further, the interfaith setting, in an interfaith setting, dealing with someone you're speaking to who have a different belief system. Yeah, how do you recommend using this art of listening, this skill set, to help you understand and communicate better? I imagine as human beings, we share things that are universal, yet language and beliefs and culture often muddy that universality of communication that we have.
Oh, I see. There are two actually answer and two positions on this. Let's take the culture. For example, there are differences. And let's say I'm European or simple language, white doctor, and there's African American, there's Asian, there are other people come to me. Does it make a difference? Apparently it would, because the lens that I see, the person doesn't, no matter how much I'm educated, multicultural, still there are areas that I don't understand. And so there are differences, the issue of power, if I'm from privileged culture. And so I think that is a good question for everybody here. Would that make, is it a particular ears or listening required to listen that process? What would I do? I mean, I educate myself, or I have to ask my client to educate me, or I just listen. So that is a paradox. Whether you assume that the culture is very important, and I have even to say, listen, I'm not from your culture, you can educate me, I'm this and that. I know you've been black, you've been this, I'm from a privileged culture, and I know there's a power. I mean, even I get to that point to make it differences here and ask that. I don't know. I think the other way is it is all an assumption. For example, I used to work here in Oakland with some working class population who lost their job, unemployed, or get PTSD, anxiety. And particularly I was working with this African American woman, and I would try to constantly, in a way, convey to her that how much I have this feeling that she's single mom, oppressed. I understand her about Black culture. And in one point, she got upset with me. She said, listen, you're talking about all of this issue, or try to ask me question. All I know that I'm depressed and you're not helping me. So we were not in the same way. I had this rescue fantasy that I have to do something in the culture. But so then what do you do? From this point of view, if you clear yourself from your anxiety, from your desire, from your racism, all of that, if you basically go under analysis as a doctor, deal with all of your issue, and then listen to the person with no judgment, and then you're allowing the person to put the pieces together. Even if you want to talk about their culture, she will talk. If you want to talk about whatever significant it is for her, she will do that. So in conclusion, there are two ways to do it. One, get fully involved, which is a postmodern way of saying that there's not a universality. Each group has their own reality and own truth, and we have to understand truth. There's no way we can generalize. The other person saying that, really, if you work on your issue as a doctor, you automatically adjust yourself through the process. I don't know how much, I mean, this is a huge topic, and I don't know how much I contributed to the answer or answering your question, Fong.
I'm sure you can teach the whole class about that as well. And I think that leads us to the topic of transference and transference, doesn't it? Countertransference.
Yeah.
And so it's arguably it's not unavoidable that happens. So what, to be a good listener, what is your advice?
Well, this notion that after you see a person a long time, the person is speaking, the person don't see you, but the person see you as somebody very important in her life, like a father, or somebody negative. So this have this illusionary view about you. And if the person adore you as a good doctor, then you also get captivated with that. And if the person constantly criticizes you and never leave you and saying that, I don't know, you're not helping me, that's called a negative transference. What do you do with that? They say that whenever the patient has some feeling toward the listener or doctor, there's always a counter feeling toward that. Like patient come, look at you as a father, you develop a feeling complementary, look at her as a son, want to help her as a son. The old traditional models say that that is a mistake of doctor to respond to that. Doctors shouldn't have any countertransference feeling because that's an imaginary way of looking at the relationship. It is not you, but you contain that feeling. Allow the person talk about you, father, and eventually can separate that you get caught up here through the process I was talking about my father. It is not you. That separation from reality to fantasy is another way of helping. We're talking about intense feeling. To do that kind of work, a lot of crazy things happen. All we have to do, look at the counselor's journal or the psychologist or therapist, that the license being revoked, because through that process, patient or client develop a lot of feeling for the doctor, sexual feeling, they're in love with their doctor, all of that. But any doctor who thinks that his patient is in love with him and want to have sex with him, and that's the extreme form, that doctor should be out of his mind, because it is not really you. But through that, I know even if this is all public information, doctors lose their license. I mean, there was a point even a doctor said, okay, I know that we are in love with each other. I'm going to give up my license. That's fine. After 3 months, they get divorced. But so here it is that responding in the name of altruism, empathy, sympathy, responding to the patient, hug, shaking hand, because physical contact with somebody who is struggling with a lot of symptoms is a different meaning for the person. And in fact, some patient with a lot of symptom even is not safe to be empathic, such as paranoid patient. It's not recommended you accept gift. They can poison you. Or in terms of empathy, if you start getting very close, the patient may develop homophobia or feel that you're going to harm. So that if you work in a hospital, especially in a hospital setting, you encounter, especially with elderly population, you have a medical problem, you have a lot of delusion coming from called cognitive disorder or cognitive impairment that bring paranoia. And they are in mercy, they want to hug you, they want to get close to you, and all kinds of complications come. So for transference, countertransference is not recommended. But the women analysts back in England and America, they're saying no. Actually, anytime the patient has feeling there's a transference, it's natural to have countertransference. And it is complementary. For example, if the patient really driving you crazy, really criticizing you, and you feel that, and really upsetting you, in her own way, the patient telling you that that is the way she was treated, that is what happened to her. That's the best form of the presenting. The patient can present her emotional history to you. So there's all level of complication. I think the spiritual work, some of this aspect of understanding in terms of transference, countertransference, listening, how to listen, what to listen, knowing a certain point the personality type, some of the symptom is important because it is not only the safety issue for counselor, pastoral counseling, and even hospital patient, elderly population, but also it helps you to relate to the person or the client or the patient better.
Thank you for tackling that question. Are there any other questions? Dr. Chavoshian, is there anything that you want to talk about that you didn't have time in your presentation?
I think we have a Dr. Levi.
Yes, we do.
Yeah.
Sorry, I was trying to get my microphone. I'm just wondering, Dr. Chavoshian, you've been talking a lot about your experience in therapy, and there's sort of, I think, to a degree, most of the people that you would encounter who would be referred to you would be people whom you previously didn't know. I would guess this may be entirely wrong, but the question I have is, for people in the pastoral setting, though, they often work with people whom they have a lot of familiarity with, their congregants or people they have relationships with. Do you think it's does that complicate the ability to really listen, and in what ways can that be addressed?
I see. Actually, yeah. These days, a lot of time when you don't have your private practice, you work in hospital, you work in halfway houses, you work in public mental health. Actually, with people you see, you have a lot of what they call non-therapeutic contact, meaning that patient come, even in the office, they need lawyer, they're struggling with their social security income, with their medication, and you ended, I'm not doing much of this work what I used to do. You ended calling so many people. If you work in a hospital, you work with the team, patient, you see patient in the canteen, in the gym, here and there, all kind of group activity. And how can you manage your individual one-on-one contact while all of these activities already shape the patient view about you, your feeling about that? That's a difficult one. I guess, one better example, I used to work in Berkeley court where I have to go to jail. The person is arrested, and among other person, inmate, and so on, I have to interview in 15 minutes to decide if the patient really has mental illness, got to go to jail or got to go to hospital. So there's all kind of, in 10 minutes or 15 minutes, how much you can do. But for some reason, give you a specific example. See, this is very important. I had this patient who started talking police, war, this and that. His speech was incoherent. It was hallucinating. And I went and tried, other colleagues went and tried to get the information. He wouldn't respond. It was too much delusion. I went there and repeated what he said. Wall, police, this, that. I didn't ask any question. In one point, he stopped and looked at me. And then I just listened to that stuff. And I said that this person is not really suffering from much of mental illness. He probably took some amphetamine, methamphetamine, drug. Just, all they have to do the blood test. But later on, because we had our office close to the police station in Berkeley, he came, knocked the door and said, there was this Indian guy, I'm not Indian, doctor there, I want to see him. He was the only person that really didn't bother me and asking me all of this nonsense question. He just was there. So the point I'm trying to make, with all of the non-therapeutic, all of the issue that you built up in a social setting, in public setting, if you keep the way you're operating in terms of listening, interaction, and truly the person could see that you're different, you truly had this sense of genuine interaction, the person will remember that. Now, in other point that you mentioned, that's a good question. Anybody from the, we have a lot of, look like spiritual director here. Anybody want to answer that? How would all of the, you're a spiritual directee in a different level, and they come to you and you want to, how would you separate those social relationships with this personal relationship? Any comment? We had, I think, Dr. Park at one point.
Yeah, so my case is like usually refer other people. It is like a small congregation. Usually it is important to have a network and then introduce other directors. It is kind of, I think, best thing. And also my case is to remind them we have a really many different dimensions that we don't know. We all explore together. So just say more about some. Actually, it's true, right? It is a mystery. Dr. Checkett, I know him. I can say I know him at some point, but still, all human beings mystery. So many part I don't know. So I think it is good to, even in starting, we say that, life is mystery, human being is mystery. So there's lots of unknown part. So let's explore together, I would say. But my another question, Dr. Ali here, in here, this is really art of listening, not mechanical or not mathematics of listening. It's really art. But you say that, you say that it is about silence, right? The silence. So you don't say anything. However, if you were directly calm and then just a silence, no answer, no response, and say more, sounds like it's very, very challenging, because in contemporary culture, silence is always anxiety provoking. So how can you really explore? How can you guide us to, how can we set up silence? This is my last question. Thank you.
Sure. There is silence for you, which is very challenging. But I guess what maybe you were asking, how about if the speaker is silent and wouldn't speak? Well, well, there's a couple areas. Usually, if he doesn't speak, say, what brought you here? Would you like to talk? Still, the person doesn't speak. Then, in one point, if the person absolutely wouldn't speak, then there's a problem. And there's a limit to that about silent listening. So, but if the person doesn't speak that long, it is not just silent. There's a lot going on in the person's mind. An example would be that we have such a thing, people who are avoidant personality disorder, they have this disorder, and they just have problem to speak because of fear of criticism, fear of judgment. And the more you force them to speak, the more they get anxious. In fact, I had a case of, I said that, listen, you heard a lot about me, you said, you called me and you waited 1 month, and then you come here, you're nothing to say. Because he wouldn't say anything. Then he got upset, hit the door and left. And in one point he came back and I asked him, what was it that was so upsetting? Then I realized that comment, the way he took it in, is not the regular comment that you and I would take. Having an avoidant personality, having the fear of criticism, like in a way he said that as though you tell me, can you see you're inadequate, have no confidence, not worth even speaking? Can you see that, how miserable you are? He perceived what I said that way. So what you do, I'm sure there are moments that became an impossibility to communicate. But then from a point of listening, there is always prompt. This is what we do, the answer to all of that. We're just talking again with formula, generality, and all of that. People are singular. They will not fit to the mode of universality, to our medical book, to all of the book the spiritual leader read, and they're trained for this. Whatever it is started in the office by speaking, listening, interaction. That is where it counts. All kind of communication start from that level. So we deal with the person on an individual level. I really couldn't answer this question the way I wanted because it's a difficult point of view. The only advice or even suggestion that it works for me, I just look at person individual. I don't assume anything, and do the best way to facilitate. And if it gets really to a point that is an impossibility, then you have to deal with it. Like any other thing, you have to deal with. So, but since we're talking let me see, Dr. Checker and Dr. Park, since we're talking about do you feel that in some of your work, even you're doing a spiritual direction, I'm reversing the question, that your directee has so much problem, you call it clinical syndrome, whatever, that it is inhibiting your work and you cannot do your work because of psychological issue?
Are you asking now?
Yes.
Yes, I have some. And then I usually refer a psychologist.
I see. Let me see. We have still, thank you, Dr. Park. We have 26 people. Are they still online? Do we have anybody from University of West, from chaplaincy or anything about our department? Are they doing internship? Do they have comment questions? Or I'm trying to entertain myself here. It's almost coming to be a monologue, but I'm curious what they do in University of West in their chaplaincy and internship.
And that's an excellent question. I think there were a few chaplaincy students online earlier. I don't see, we had a adjunct professor here as well, but I don't see her anymore. That's a good question to pose to the department.
I see.
We'll keep that in mind. We've passed over the 90-minute mark, Dr. Chavoshian. Are there any other questions? Otherwise, Dr. Chavoshian, do you have any last remarks?
Oh, I think we cover a wide range, and I think I'm fine. I'm fine, and I think I try to simplify it and not make it too much clinical, and then other thing for sure is listening is not simply just the common sense listening, and speaking is not the common sense speaking. That's the reason why conversation between two people is important. Anybody who speak with a friend and converse, they're going to feel better if they have a problem. But there's a point that there's a block, impasse there, because no listener can fully abandon his or her lens, neutrally listen. That's the reason why we say that listening and speaking in an analytical setting or any similar setting is not just a conversation. And it is not pedagogy either, because education has its limit. You know, you can educate people as much as possible and they can understand their problem intellectually. But the problem, emotion, has no logic. Emotion has its own irrationality. It's an impulse. It takes over the person. That through pedagogy and through education, it cannot be corrected. So what we need then is the knowledge, the science of analysis. And that is precisely a process. And it's unique. And it happened between doctor, spiritual leader, or individual or group. And it is more than just the consciousness perception of the problem. What we call reality is fabricated. We assume reality is real. Reality is not real. Each reality has something behind that. Reality or truth that presented is always mixed with lie. Half of the thing we say is truth, and the other half is lie, censorship. And precisely this is process that through this process, just the friendship and conversation is not gonna dig into it, go deeper, require analysis or any kind of thing. All right. Thank you for listening again. That's my end for my part.
Thank you. I think that would make the nature of reality would make a great topic for the next lecture. We hope you come back very soon. I think there would be a lot of interest for your next lecture. I think I speak for everybody who have stayed on to listen to the end of this lecture. Once again, thank you, Dr. Chavoshian. And thank you, everyone, for being here. If you're interested, we'll make this video available for everybody. We'll make an announcement at some point when it's available, and we hope you can join us again soon. Have a good night, everybody.
Well, thank you.
Thank you.